afternoon, everyone. Thank you so much for being able to make it this afternoon and join us. But first of all, let me say Happy Mental Health Day to everyone from wherever you are joining us. My name is Anna Sango, and I'm the Global Advocacy Officer for GMP Plus, and we're super excited to have you join us today. So I have an amazing group of panelists that are going to be presenting today as we share around the work that we're doing around mental health, but also looking into issues to do with an internalized stigma and the intersection with people living with HIV. So I do hope that we'll all stay tuned in onto the webinar so that we can learn, and then we can also have an opportunity to discuss some of the issues and also some of the interesting insights that are going to be shared on this webinar today. So as you all know, today is World Mental Health Day, and different groups and different people are commemorating it in different ways. And I do hope that all of us will get an opportunity to take some time out and be able to check on ourselves and to check on our mental health, and also to do just something that will help us just kind of like refocus, reorganize, and just take a breather from the busy schedules and the busy work that we do within our respective spaces. So without wasting any more time, I just wanted to, before we start and hand over to the first speaker, I just wanted to showcase this slide. And the slide is linked to the work that we do as part of the People Living with HIV Stigma Index. And we recently launched a global report last year. And then this report really speaks to the different types of stigma that people face around external stigma and also internal stigma that people living with HIV face. And then I just wanted to share this with you just as we start off the conversation, that overall 84.8% of respondents who are living with HIV agreed to with one or more of the statements that are shown on the screen around how difficult it is for them to share their HIV status, and also how they hide their HIV status from others, how they also feel ashamed that they're HIV positive, and how they feel guilty about being HIV positive, as well as how that makes them feel worthless. And sometimes, or in some cases, they feel that they are dirty just because they are HIV positive. So these were some of the sentiments that came within the internalized stigma data that was collected during the PLHIV Stigma Index. And today we're just going to be hearing more around the work that is being done by different institutions, different networks, and also different organizations around addressing stigma and discrimination, but mostly looking at what we could do to ensure that we have specific interventions around mental health, and we ensure that we have specific interventions around addressing mental health within the different settings. So I'm just going to call upon my colleague, Sasha, who's going to give us the first presentation. Sasha, if you're ready, please do.
Before we go ahead, Anna, I just want to mention that we do have translation in different languages. We have translation in French, Russian, Spanish. You just have to click on the globe sign and choose the language that you would like to listen to. And if there are any Portuguese-speaking people on the room, please let us know, raise your hand or let us know, and then we will make sure that we make that available for you as well. Thanks.
Thank you so much, Lester, for that. Is Lester, our communications manager. Thank you. And if there are any challenges, please do post and let us know, and then we can be able to assist. Sasha, if you're ready, the floor is yours.
You see my screen? If you see my screen, I'm ready.
Yes, you do. Please go ahead and introduce yourself and
yes, sure. Hello, everyone. Happy Mental Health Day. Yeah, this is important topic for me, like personally and professionally. Yeah, my name is Sasha Volgin. I work for GNP Plus. I'm the community partnership and network manager. And let's talk today about like how we see, from the community perspective, the mental health and let me start maybe with the COVID-19. That was a moment, yeah, moment of crisis for sure. That was very hard for people living HIV around the world, and we all had the fear of loss access to medical care, to our treatment, which is the most like important, right? Then there was also quite a lot of, if you remember, in the beginning of epidemic, there was this this is worse for people living HIV. We're all gonna die, So there was a lot of anxiety and a lot of, like rumors, a lot of information going around. Of course, that was a period when the stigma and discrimination, especially to people from the key populations, and a lot of people living HIV are from key populations, was like extremely high towards people who use drugs, towards sex workers, towards trans community. So that was a really hard moment for many of our comrades, and rates of violence, both like just domestic and just in general, and loss, and of course fear or the exact loss of income and worsening of financial situation. So that what we all were experiencing during the COVID pandemic. I think we have done a great job as a community of people in HIV across the global adapting to that. So what we've been doing, a lot of organizations have done the support hotlines. A lot of have done, we came back to our roots, support groups online in that case, because obviously we couldn't meet in person. And many services at that moment actually, and I will speak about that later, because now it's quite a good resource, because now we know how to do a lot of things online. So many services were adapted to function online. I think absolutely great job was done. While the medical systems were adapting, we were delivering treatment, essential commodities to our members of our community, and that was a great job done. Yeah, we started, some psychotherapy, some, special sessions. I think that was the moment when the community, we started, like really work on that, both from activist side, those who are working in HIV, but also those who are just, people living HIV. So at least some basic psychological support needs. Of course, shelters and social support services also was, and as I said, burnout prevention. Yeah, because also for those working, it was also quite a hard moment. So that actually was very, then I was very involved, of course, and among the, colleagues across my region where I'm coming from. So we saw how then, it was changing when the war came. So in the beginning of the Russian invasion, thanks God, before was the COVID, actually, because that was the time we adapted to do the things online. And I think for future, we also, as a community, we should think and consider that, because we also know that there's more and more repressions, more and more pressure. And online is our piece of freedom, is our opportunity, to do the things when you can't do that, in person. It's in the war situations, it's also in the repression situations. The far-right movement is growing across the world, so this is not, only my region, but, like transferring our support and our like peer-to-peer things online is quite a great approach. So let's go back to Russian invasion. So yeah, in the beginning, it of course was all about everyone was working, 14 hours per day. So it was burnout prevention programs. It was for doctors, social workers, peers in Ukraine. People were working hard. And it was like 2022, it was hundreds of sessions. Uh, Basically, it was the COVID, which should have been addressing the mental health around COVID, which was transferred in to be the one working around the war. So what other great, absolutely great experiences and a great example. So Positive Women Ukraine, they have done humanitarian help together with the online consultations of psychiatric doctor and distribution of medications, so that you can have a session with the psychiatric doctor. The doctor then can prescribe you medications, and then they can go and get these medications in your pharmacy. So that's how it works. More than 300 women living in HIV across Ukraine have received that help. I think that's a great, example how the communities can really, really bring the services, close to the clients, even in most hard situations. Over 300 people received psychotherapy. The project is still working and still helping. So in Poltava region, there was a special mental health hub. Hub was opened for especially internally displaced people, people from key populations, and HIV positive people. So also we have to take into account when we're building our interventions that, of course, people in HIV have much more risks, as they already, as we saw in the first slide when Anna was, starting this webinar. We all know that we have additional burden of being, HIV positive and of all that kind of feelings, and then, together combined with the special humanitarian situations, it became really hard to, to navigate. As I said, the COVID-19 experience was really life-saving. So what about refugees outside Ukraine? Being a refugee, being in the population on move, and there is now, it is growing because of the climate change, because of the wars, because of everything. We have more and more people on move. So we need access to vital treatment. And the main fear that comes with it, it's an anxiety not to get it. So then it's also followed by self-stigmatization based on medical criteria. All that on top of all the, fears and of instability, war, and everything, trauma. Fear of being discriminated due to HIV or being from key populations, mental health problems associated, with the deviant risky behavior and the risk of alcohol and substance use. Honestly, it was a shock for many community organizations in Europe because we were trained, to work with people living HIV, but not with the refugees. So I remember in the beginning of the war, people calling me, from Moldova saying like, Sasha, what we're gonna do? These people, they are drinking and they're just looking into the wall. They're not gonna do anything. Like, well, how are we actually supposed to work with them? That was a moment when everyone was trained, like really to adapt and to understand, how to work with these people, how all that does work. So, yeah, as I said, no previous experience. So Moldova case actually one of my favorite ones as well. The organization I've been telling you about, they made a great job at the end of the day. So they were providing primary and specialized psychological support, so mental health services. They were actually using, again, online technologies. So it was a Telegram chatbot in 3 languages, which was making screening, then referral, and was giving people basic self-support tips, what to do. So they have supported over 50 peer counselors and social workers from 8 organizations to provide also the screening, primary psychological counseling, referral, all that. kind of services. So it was, in person, but it also was online in Telegram. Quite big amount of refugees have received the screening and services, primary counseling, and specialized counseling. So yeah, that's one of the experiences across the region. What you can do when you are in this kind of emergency and humanitarian situation. Let me speak a bit about my own experience. So the first year of the war was very hard for me personally. I was working 12, 14 hours a day. My husband joined Ukrainian army. I was having refugees hosted at home. So at the end of the day, all that resulted into depression. And I went for help. I went for treatment. My husband was 9 months on the front lines, which is quite a burden for everyone. I also have kids here, work to do. So my call here for all of activists are, we are also experiencing quite a lot of pressure. So in that circumstances, don't think twice. Just go and get your psychiatric help. There's nothing to be ashamed of taking, pills and receiving professional help. So just go and take care of yourselves. As I did. So my husband is now back, thanks God. He's alive. Well, he got NDR tuberculosis, and now he's in PTSD treatment because obviously the war is a very high costs, let's say, for individual, to be fighting for his country. But anyway, just for every one of us to be aware, we are also human beings, and we also have, while we're building, I was building all that programs, for other people, while we're building the programs for the other people, it's also very important to think about yourself and what is going with you. And don't be ashamed, that's okay. So also a bit of about the psychological support for the human rights activists. This is relevant for many regions, unfortunately now, because especially for LGBT community, but in general as well for all the how human rights issues are now getting worse and worse. We all know. So what are the approaches? In the beginning, like several years ago, there were like repressions in Russia, but it wasn't so bad. So at that moment, if your country is, for example, is not in such bad situation yet, right? What we discovered? We discovered that sometimes, the lawyers are defending activists in the court, but the activists themselves are in such an awful psychological conditions that they can say something against, themselves, that they can't be able, to show up in the court. Like we understood that, it's not possible to give like legal support for activists while we're not taking care of their psychological state. In the beginning it was just, like bringing psychological help so that it would be possible to help people, to not to get into prison. And so several years ago, unfortunately, the situation is, worsening and worsening. So lawyers were to involve psychologists then to help, not only to defend those under repressions properly, and journalists, were like, making cases publicly. But now, when the people have to escape, even lawyers and journalists have to escape from the country, and then they need already support, and sometimes it's pretty, hard interventions, like the interventions which are about evacuation or suicide prevention programs. I see Anna, and I'm speeding up. So the last thing I wanted to speak about is that I think we need more data. We need more data and more understanding of what is going on with the with people living HIV, especially in the humanitarian situations. So we're gonna, fingers crossed, we will get funding from United States government. We have filed the project for research to look into exactly PTSD, post-traumatic syndrome, anxiety and depression in Ukraine, and its connection with the substance use, because there's, surprise, surprise, people in that, conditions are usually very vulnerable for using substances as well. So we are gonna make research in Johns Hopkins University together with JNP Plus and Light of Hope. It's a local community-led organization in Ukraine. We will be looking especially into such populations as men in armed services, women who are very much affected, people who use drugs. So we are going to look into this, drug use, mental health, or being HIV positive or from key population. So let's see what will be our results. Also, I'm encouraging you, if you have also, interest into that, please reach out. Let's think, I think we need more data and we need more attention towards that kind of troubles. I also hope that the worst scenario is that people, in Ukraine being in a really hard mental state, of course, people start using drugs, and then they are criminalized, and then they will just, especially those who were defending us on the front lines, will get into prison. So I also hope that this kind of research and work also will help us to advocate for drug use decriminalization and for providing people rather help and support and not prisons. Yeah, I think that's it from my side. If you are interested, if you have also some ideas in that, in that area, please reach out. Here's my mail. And in JNP Plus, we really think that this is a very important part, mental health, and we have to take care of ourselves and of other members of our community. Thank you.
Thank you so much, Sasha, for that enlightening presentation around the work that we're doing as GMP Plus, and also how we've been working also with other organizations as well as institutions around making sure that mental health is a priority for people living with HIV, more specifically looking at when there are humanitarian crisis, because we know that within that particular time, there's a lot that is happening and there's a lot that is there to grasp with. And usually the most forgotten communities are people living with HIV, in terms of the anxieties that they'll be having around the continued access to medication, but also really just as human beings, whatever is happening, it affects them in addition to being a person living with HIV. So that's important that you shared that, and I appreciate that, and I'm pretty sure the audience that we have really appreciates the role and the work around mental health. So moving on, we will have a question and answer at the very end. So if you do have any points of clarifications or questions, please feel free to just note them down. And we do also have a Q&A space. So please do post any questions that you may have on the Q&A. And then also, if you want to interactively engage as well, we will open up that opportunity at the very end of the presentations. So now I'm going to welcome colleagues from Reach Nexus, James and colleagues, who are going to speak around some of the research and the data around stigma and discrimination, but also with the link to mental health. So James, please do take the floor.
I will. Thank you very much. So Alex is going to share our slides, and I'll be saying next a little bit. But so this is us. If you could just flip to the next slide, Alex, that would be great. So before we begin, are you able to flip to the next slide, Alex? Oh, yes. Before we begin, I'd like to acknowledge the land where Reach Nexus is based in Toronto, Canada, on the traditional land of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And today it's home to many First Nations and Inuit and Métis communities. And we respect and honor the enduring presence and resilience and rich cultures of Indigenous peoples. We also acknowledge the ongoing injustices they face and commit ourselves to the work of reconciliation. Next slide, thanks. So we're just going to introduce ourselves here. My name is James Watson. I'm a research manager at ReachNexus. I manage the HIV stigma initiatives. I'm a person living with HIV. I started my career as a peer researcher, and I also produce and host a podcast called Pausecast. And I'm very excited to be here, to be invited onto this global stage to talk about our work and this very important issue. Jason.
Hi everyone. Yep, I'm Jason. I just finished my PhD at the University of Toronto, and I also work with ReachNexus, mostly working on the stigma index data.
And that leaves me. Hi everyone, my name is Alex. I'm a research coordinator here at ReachNexus. I'm also a person living with HIV. I have an academic background in public health, and just very excited to be here with you all today. And I'll toss it over back to you, James.
Thank you. Next slide would be great. So this is what we're going to touch on today. I'm very aware of time, so we will get through this as quickly as we can. So next slide. Thanks, Alex. So who are we? So ReachNexus is part of the MAP Center for Urban Health Solutions of St. Michael's Hospital in Toronto. And we're a national network of academics and researchers and community leaders and people with lived experience focused on turning research into real-world solutions for people living with or at risk of HIV and hepatitis and other STBBIs. And one of our biggest projects that we're working on is the HIV Stigma Index, which is helping us understand the effects and impacts of stigma and discrimination. And we're at the very final stages of data collection, but we're always using the information as it comes in to support stigma reduction campaigns and targeted interventions and knowledge sharing efforts that Jason will touch on a little later in the presentation. Next slide, please. So just to give you a quick look at the HIV landscape in Canada, to give some context, by the end of 2020, around 63,000 Canadians were living with HIV. And of those living with HIV, with an eye on the global 95 targets, 90% of people living with HIV have been diagnosed. 87% of those diagnosed are on treatment. 95% of people on treatment have achieved viral suppression. And then fast forwarding to 2022, there have been 1,833 more people diagnosed with HIV. So that's a national rate of 4.7 per 100,000 people. Next slide, please. So HIV can affect anybody, of course, but certain populations in Canada are disproportionately impacted because of social and structural factors. These groups are outlined here on the slide, but we have to remember, of course, that HIV risk is shaped by life experiences and systemic barriers, not simply by belonging to any of these groups. And building on the strengths and resilience within these communities is essential for improving health outcomes. Next slide, please. So we've been working on the stigma index since 2017. It's been a huge, long, collaborative effort, but it's been, it's been very rewarding work. We finished data collection in all 10 provinces. We've completed about 1,620 surveys, and now we're focusing our attention on the Northern Territories. Along the way, we've certainly faced our share of challenges, like the global pandemic, like COVID, and switching stigma index versions midway through implementation. And we went back to 3 provinces to collect data, but we've also had the opportunity to add region-specific questions focused on U=U messaging, as well as validated measures to help measure stigma and mental health factors and health factors. And one of the key aspects of the stigma index, of course, is people living with HIV engaged in the study as community researchers, or as we call them, peer researchers. And ReachNexus and our regional partners have hired and trained and supported over 40 people living with HIV in this role. And this is where I want to highlight our approach to supporting their emotional and mental health, because it's key to the success of this study. Next slide, please. So in the stigma index, people living with HIV were trained were trained as peer researchers and meaningfully engaged throughout the project wherever feasible, from recruitment, especially with hard to reach populations, and data collection to analysis and dissemination of results. The role for us was never just about data collection. It's about capacity building and skills building and supporting leadership and putting JIPA and MIPA into action. It's not perfect. You know, community-based research can be messy, but lived experience is expertise, and we as a team won't put a step forward without it. You know, where would we go? So, you know, we do our best to offer 4 main pillars of support to help peer researchers feel confident and empowered in their roles: emotional support, practical support, educational support, and cultural or spiritual support. And they all work together synergistically, but I want to focus briefly on emotional support. You know, one of the toughest parts of being a peer researcher is constantly having to disclose your HIV status. It's necessary for the work, but it can be really emotionally draining and blur the lines between the personal and the professional. It's a very stressful line to walk all the time. And another challenge is the emotional labor that's inherent to the role. It takes a mental toll, sharing and hearing the personal stories of participants, especially participants who may have gone through similar trauma as yours. Anxiety and depression can easily take hold without the right support. So our job was to make sure peer researchers felt valued and supported and heard, and provide the opportunity for ongoing emotional support throughout their time in the study. We encouraged peer-to-peer support and offered regular debriefing sessions, often immediately after an interview, so no one felt isolated or left to carry the emotional weight alone. And in training the peer researchers, we equipped them with tools for emotional first aid, managing triggers in the interview, and peer debriefing skills to help build resilience and emotional confidence. It's so important that peer researchers feel supported in their feelings to help avoid an inevitable burnout, you know, which is something seen frequently in roles that require a lot of emotional labor, like healthcare workers or counselors, or even waiters or cashiers. So good mental health is key to the success of any community-based research team, but especially in a study that's investigating deeply personal issues around HIV stigma. And with that, I'm going to hand it over to Jason, who's going to dive deeper into our data around mental health and highlight some of our KTE activities. Thanks.
All right, thank you, James. So let's go. Take a look at some of the data around stigma and mental health. We just have a few examples here of certain questions. Overall, we did see quite high rates of stigma in Canada for the HIV stigma index. For example, 50% of the sample said that people have physically backed away from them after learning they have HIV. This is an example of what we call enacted stigma, or actual experiences of prejudice or discrimination. We saw that over half, 56%, said that they feel ashamed of having HIV. This is that internalized stigma that we talked about earlier. And about 3/4 said that they are careful who they tell they have HIV. This is kind of a representation of what we call anticipated stigma, or expectations that others will treat you differently because of your HIV status. We also saw that people can struggle with their health and their mental health. We had a quantitative scale that measures depression called the Patient Health Questionnaire, and we saw that 40% of the sample had significant levels of depression, and also 1 out of 5 said they had poor overall health. On the following slide, you can see we worked really hard to get some of the to write up some of the data and to get it published in academic journals. This was part of my PhD work, and it was mostly focused around trying to understand how stigma affects health. And on the following slide, you can see the framework that came out of this work, it mostly focused on understanding how different manifestations of stigma, which includes internalized stigma, can affect health-related quality of life, and which mental health is included under that. I won't explain it fully, but you can see how how stigma leads to certain factors, and we were trying to understand some of the factors that make up the pathway between different types of stigma and mental health and overall health, and also what factors may change the relationship or modify the way that this relationship works. On the following slide, you can see some examples of some of the models that are built from the quantitative data that we have. On the left-hand side, for example, we demonstrated how enacted stigma, this is that discrimination and prejudice, we demonstrated how this leads to worse levels of internalized stigma and depression, which in turn has a negative effect on somebody's overall health. And on the right-hand side, we also demonstrated how internalized stigma leads to worse mental health by increasing levels of anticipated stigma. And on the last slide, we focused on trying to make these findings translatable and understandable for community members and the general public. So we took many of the quantitative research findings that we found and turned them into outputs such as blogs or videos or podcasts to make them accessible and understandable to the communities and the people who are most affected by these problems. And so you'll see a link to the website at the end of the presentation, but I encourage you to check out all the work that we've done. Okay, I'll pass it on to Alex to talk about the future of the program.
Thank you, Jason. There we go. So from data to action. So really, I'm going to be highlighting, something we call the Positive Actions Initiative. Its formal title, Positive Actions Breaking HIV Stigma. And so really, the Positive Actions Initiative was created out of, the clear need for stigma reduction efforts as seen through the data collected in the Stigma Index. And the data from the Stigma Index was actually really integral for our team to receive funding in order to launch this initiative. And so first, I just want to set the stage. And so a positive action is an intervention. Both are meant to promote health at a variety of levels. And ultimately, the term positive action was decided through our community advisory committee because the language just better aligned with the team's values. And so really, at the end of the day, the goal of the initiative is to empower peer leaders, people living with HIV, to lead stigma reduction efforts in their community. And so 10 positive actions will be funded throughout the initiative, and each positive action will receive up to a $20,000 grant. And so really, we have designed this initiative to attract small grassroots organizations or teams to really allow for more community-oriented actions, more on the groundwork to be done to reduce HIV stigma. And so I have presented on this slide 3 out of the 10, so these are the first 3 funded projects that we have. And at its core, all these projects aim to address HIV stigma, including internalized stigma in some way, and which in turn will lead to better mental health outcomes. And so the first one I have here is, why aren't we talking about it? HIV stigma and harm reduction services. And so this positive action aims to address the challenges that clients who use harm reduction services face in small, urban, rural, and remote communities in British Columbia. And so that is one of Canada's western provinces. And so this team is creating a workshop kit in collaboration with people with lived experiences, and will implement this kit within social service organizations with the ultimate goal to increase HIV treatment and also reduce stigma associated with drug use and HIV. The middle one here, titled Young Women's Stigma Reduction Project, is a positive action that aims to provide young African, Caribbean, and Black women an opportunity to really reclaim their sense of well-being and promote inner strength. And so this takes place in Toronto, Ontario, Canada's most populous city. And so this positive action will implement peer-led, group-based educational workshops to reduce HIV intersectional stigma and also overall support young Black women ages 16 to 29. And then finally, on the right side here, digital storytelling capacity building for people living with HIV. And so this positive action is based out of another Western province in Canada, Alberta. And so this positive action uses digital storytelling to really empower people living with HIV and allow them to talk about their experiences of stigma in a safe way. And this positive action focuses on the strengths specifically of people living with HIV. And the ultimate goal for this one is to really use the stories created through digital storytelling to re-engage community and really have those, thoughtful and real raw conversations about HIV stigma. And so building momentum. And so, like I said in the beginning, ultimately, this initiative was built off of the momentum created from the Stigma Index. We are now implementing these projects to actively reduce HIV stigma. And through this, we'll be able to learn more about what effective strategies, really work well in the communities. Again, I really want to emphasize that this initiative really grounds itself in, the butterfly effect. And so really all positive actions are valid, we feel. One small action can really create significant change. We really believe that one project can cause ripple effects and really create larger change in the community and really inspire future actions as well. And I want to end off on a message, just, relaying to everyone that, like James said, we are wrapping up data collection for the Stigma Index. And with that, we are also looking for opportunities to engage in knowledge mobilization efforts and really share this data with others. It would be great to work with other teams who have currently or previously implemented the Stigma Index to really see how we can work together and promote this data really on a global scale. Because at the end of the day, this is valuable data and it's really important work that we are all doing. And it would be amazing if we could use it to, promote education efforts about HIV and HIV stigma, change stigmatizing policies, and really, engage in HIV activism as well. And so this last slide here is just our contact information, our website, the Positive Effect website. And yeah, I really just want to thank everyone for listening to our presentation today. And I hope to be in contact with some of you soon. Thank you.
Wow, thank you so much, James, Jason, and Alex. This was a really intriguing and very interesting presentation of how you took us from understanding mental health and the impact it has on different individuals and the impact it has even as a person who is in the forefront, whether leading an organization, whether a peer supporter in the community, or just the person who's living with HIV, who is the recipient of care, how mental health kind of has an impact on our lives and our work and also our overall well-being. And thank you also, Jason, for really bringing that picture around the data and how important that data is and how important it is to utilize this data and really bring it to life. And thank you, Alex, for just bringing the picture around the actions that we can pursue and the actions that can take place in terms of in terms of bringing that data to life and also speaking it to the people so that people really understand and appreciate it. Because in most instances, a lot of researches and studies are done and then the data is just kept and it's not utilized and it's not used. And that becomes a challenge because we never get to realize the goals and the work that we really need to be doing. So this is very important. And thank you so much, guys, for really sharing this. This has very been intriguing and very informative. I do see that there are some questions that have been directed to you, Alex. So if you can have a moment as well through the Q&A. There's a question from for Alex Tran, interested to hear about the specific strategies from Daedra. So if you could be able to just respond to that, that would also be great. But even at the end of all the speakers, if you then want to just kind of speak to that as well, that would also be very good. Thank you so much for that. And it's only ideal now that we have Simi come on and present, because Simi is from Finland and they've also just recently completed the stigma index. So we'd really love to hear around what were some of the key issues that came up around mental health, and also how has been the experience in terms of implementing the stigma index, and what are some of the plans that you have right now around then coming up with interventions to address mental health, or to strengthen the systems that can support mental health for people living with HIV. Sydney, you're up next.
Thank you. So I'm sharing my screen. Is it okay? You can see it?
Yes.
Okay.
Yes.
Good. Thank you. So my name is Sini Pasanen, and I'm from Positiivis at HIV Finland, and telling you something about the very recently published stigma index report, some results from the stigma index in Finland. So Finland, kind of a small country in Northern Europe, here up north in the corner of Europe. And as said, Positiiviset was the stigma index implementer in Finland. The data was collected in 2021 to 2022. So we actually faced some challenges with the COVID pandemic, and we had to pause the whole data collection, and it was a bit difficult to kind of restart after COVID pandemic. But we managed to get 53 interviews and 12 semi-structured in-depth interviews. As a bit comparing to Canada, we have a population of 5.6 million and a very low prevalence country, having 3,500 people living with HIV, plus approximately 200 people living with HIV who are undiagnosed. So few of the results that are related to today's the topic. So I'm going to say something about disclosing one's HIV status, experience of stigma and discrimination, internalized stigma, and interaction with healthcare. Yes, so experience of stigma and discrimination among the respondents or the interviews, 35% had heard others than family members gossiping or saying stigmatizing things. 31% had been verbally threatened or abused. 22% experienced blackmailing. 17% experienced family members gossiping. 16% decided not to participate social gatherings. 13% didn't get a job or lost a job or source of income. 12% told that their spouse, partner, or own child had experienced discrimination because of their HIV status. 9% told that the job description changed or the promotion was refused. And 8% told that they had experienced physical harassment or assault, for example, pushing, punching, or other physical violence. About internalized stigma, 74%, as you see on the left side, felt that it was difficult to tell about their HIV status or disclose the HIV status. 26% said that it wasn't that difficult. Also about the internalized stigma, 68% told that they hide their HIV status from others. 21% said they feel worthless because of their HIV because they are living with HIV. 36% were ashamed for living with HIV, and 23% said they feel guilty that they are living with HIV. Some effects that we think were kind of alarming in our country, they're on the right side. The other effects that people told happened during the past year or 12 months. So 11% had made the decision not to seek healthcare they needed because of their positive HIV status. 10% decided not to participate social gatherings, and 18% decided not to have sex. And this had just happened quite recently at the moment when we were interviewing people. The non-HIV related healthcare. So in our stigma index, all interviews were on medication or RT, and most felt that their general health was quite good. Only 9% felt unwell. 18% said they were kind of doing on average good, and 72% said they felt their health was good. The possible recording of clients' HIV status in healthcare system has caused, and we know this is we hear this quite often, and continues to cause still concern and stress for people living with HIV, that you don't know what is said about your HIV status and who knows about it. Knowledge of the interview's HIV positive status has led, for example, to the doctor or nurse assuming that the person was using drugs or had poor life management. And these people had heard from a doctor saying that, like, do you have some other issues as your life management is quite poor, kind of referring to a person living with HIV. So in Finland, you don't, by the law, you don't have to disclose your HIV status. So 60% tells about HIV when they are seeking other healthcare than HIV healthcare. And 40% they don't ever tell. They don't disclose their HIV status when going to a dentist or a doctor or any non-HIV related healthcare. 57% they are sure that their medical records are kept confidential and not shared without written informed consent. 26% are not so sure, don't know, and 17% said that it's clear to me that my medical records are not kept confidential. Here is one example, what we heard in 2022. A nurse told me after booking a doctor's appointment at the health center that I should make sure that I won't infect the doctor in the consulting room. So these were my slides. And I think there was also the question that how we are going to use this information. So we've been already during maybe 1 year kind of publishing some of the results, not the whole report, but some of the results, and using it in our communication. But also when we are talking about the results, it's kind of inspiring people to start sharing their experiences and what they have felt. So our plan is to kind of try to have a website where we publish the results, but also at the same time when people are reading the results, there is a possibility for them to write or share another way what they think, how they felt, how they experience stigma and discrimination, or certain topics that kind of what the results are speaking about.
Thank you so much, Sini, and thank you for the great work that you've done in terms of the stigma index implementation in Finland. And I think this just goes to show and aid on to also some of the data that has been presented around how people who are living with HIV feel about when it comes to disclosing their status, and also when it comes to being around people, and also when people know their status, how they feel they treat them, and also how they feel they need to be engaging with different people. I think it's important, and it's really also just emphasizing the point around how much internal stigma has an impact on people living with HIV, in as much as the external one has, but also the internal, the the risk of depression that people living with HIV can face, the risk that they have probably in terms of interrupting their treatment just because they are struggling with a lot of emotions and with a lot of anxieties and with a lot of feeling of unsafe and feeling unsafe because of what people feel or what people think about them or towards them just because they are living with HIV, the judgmental attitudes, even within the healthcare facilities or within the environment or the family. So thank you for that, and congratulations for implementing the stigma index.
Thank you.
And we really look forward to connecting and collaborating the work. So it has been really interesting hearing from all the speakers around, how internalized stigma can really have an effect on people living with HIV, and how that in turn also affects the mental health of people living with HIV as well as people in general. So right now we're just going to move on to a video that was done by Beyond Stigma, which is also an explanatory video around internal stigma and mental health. Lesego, are we ready with the video? In the meantime, while we're waiting for the video, I see there are some comments that have been made also within the question and answer. So to all my panelists as well, please feel free to share your thoughts as well. I see there's a comment from Chang from Taiwan. So please feel free to share any sentiments that you have in terms of that. And also our chat has been very much active. Thank you everyone for engaging and being so interactive within the chat. Also, please do utilize those two platforms for any questions or clarifications. Is the video ready?
Yeah.
Have you ever had the thought, I'm not good enough? Have you ever questioned your self-worth or felt ashamed about yourself? This is what we call self-stigma, the negative self-judgments that you can have towards yourself that result in feelings of worthlessness, shame, guilt, and low self-esteem. Probably heard of stigma, otherwise known as social stigma. Oftentimes, we think of it as prejudice or discrimination towards someone because of a particular trait. It could be a disease, disability, the way they look or talk. Self-stigma is much less known, but can be experienced even more than social stigma. Self-stigma can be extremely harmful to your well-being, leading to depression.
You can't see the video.
Yes, the video is not showing. We can see the
We
tab
can
that you
hear it only.
We
Oh,
can
you
hear.
hear it. Okay,
Yes,
I was
we can't
seeing it. Let me try again. Click. Can you see the screen now? My screen?
Yes, we can.
Okay. Do I start? It's not allowed.
Have you ever had the thought,
Can you see it?
not good enough?
Thank you.
Have you ever questioned your self-worth or felt ashamed about yourself? This is what we call self-stigma, the negative self-judgments that you can have towards yourself that result in feelings of worthlessness, shame, guilt, and low self-esteem. You've probably heard of stigma, otherwise known as social stigma. Oftentimes, we think of it as prejudice or discrimination towards someone because of a particular trait. It could be a disease, disability, the way they look or talk. Self-stigma is much less known, but can be experienced even more than social stigma. Self-stigma can be extremely harmful to your well-being, leading to depression, anxiety, low self-worth, isolation, and even suicidal thoughts. Anyone can experience self-stigma. We see self-stigma amongst people living with HIV and obesity, transgender individuals, sex workers, those diagnosed with COVID-19, children, adults, and the elderly. Notice the next time you find yourself thinking, I am ashamed of myself. I am unlovable. I am worthless. Everything is my fault. Stop and take a moment to remember that all of our thoughts are not always true. This is self-stigma, and these beliefs are not facts about ourselves. In order to combat self-stigma, we need to recognize our negative thoughts and judgments about ourselves. Beyond Stigma works with different groups of people all over the world to help identify and break down self-stigma by teaching people to question their thoughts, find ways to express themselves, build confidence, and create community. We can transform self-stigma into self-worth.
Thank you, Lesego, for sharing that. Yes, that was an interesting explanatory video, and also just a good opportunity to just take a break from the first batch of presentations that we had, because I do know that it's a lot of information to take in as well. And so yes, that's interesting in terms of the internalized stigma, and also how that has an impact on how we feel about ourselves, and also how we view the world and other people around us once we kind of feeling a bit low and down and depressed. So that was informative to know, and realizing the effects of internal stigma, and also trying to be able to see how best we can be able to address that through the different initiatives, and also through the different work that different communities of people living with HIV are doing, and organizations. And speaking of which, we're going to have Maud next, who's also part of the Beyond Stigma. Maud, sorry, I hit my video off. Maud, are you ready to take the floor? Yes, please. Yeah, please introduce yourself. Yes, please introduce yourself, and then tell us a bit about your experience in terms of mental health, and also the work that you're doing at Wakakosha.
Okay, thank you so much, and thank you so much, Anna, and thank you for the previous presenters. My name is Maud Chinembiri, and I'm the project officer for Wakakosha here in Zimbabwe, and Beyond Stigma and Zhandiri. So I'm just going to share about one of the projects that we are currently doing here at Zhandiri. I think you can see my slide, right?
Yes, okay. We can.
Okay, thank you. So I'm just going to break it down. One of the things that we are doing, we also want to share about stigma, what is stigma, and what is discrimination, and what is internal stigma. So this is one of the things that we have seen, that many people, they don't understand what is stigma and what is discrimination and what is internalized stigma. So we always want to identify internal stigma and tell people exactly what is internal stigma. That stigma, this is like what happens. I don't know if you can see my screen.
We can, but you can put it in presenter mode. Okay.
Okay, so stigma is when you think negative things about me because I'm living with HIV. These are other people thinking about me. And then discrimination is when you do negative things to me because I'm HIV positive. And then internal stigma is when I think or say negative things about myself, or do negative things to myself because I'm living with HIV. So I'm just gonna move straight to this diagram that you're going to see, which is called the socio-ecological diagram that describes a person living with internalized stigma. As an individual, if I'm living with the internal stigma, for example, for me, when I was living with internal stigma, I could not access treatment. I stopped adhering to my treatment. And then that's when I started getting sick. And then I could not even drink my medication and take my medication well. And then at family level, I stopped even participating in other scenarios of life. I could not go to weddings or family functions. And then at community level, I didn't want to talk about my status. I didn't want to see people. I had an attitude. I didn't want to go to church. And then on structural level, I didn't want to take any opportunities. But when I found this work that I'm doing right now, which is called the Wakakosha program, I realized that as an individual, I can take access. I can take charge of my life. I can take treatment. And at family, I started also participating in other social gatherings. I started going to weddings. I'm so happy that even last month I was also having a wedding at my house, and I also participated in that wedding because I fought my self-stigma. And then on community level, now I can also go and also share with other peers who are just like me. And then I can share about my status. I can also share how I managed to be where I am right now. And then I'm now free to also share. I go to different community gatherings, community activities that are done in my community. And then on structural level, I've taken the opportunity. Now I'm also a project officer with Beyond Stigma in Jandiri. And then I can also share with other young people and young women and young mothers like me. That's why I'm actually doing this Wakakosha project. So the Wakakosha program, the overview is that we have seen that globally, like Anna was saying, there is a percentage like 37.6% globally of internalized stigma. And then with Wakakosha program, this is what we are dealing with. People, they say they are ashamed, they are worthless, and they are guilty. So the Wakakosha program, the overview, is that we have integrated the Wakakosha program into a peer-led program that is called the CATS program that we are doing here in Zimbabwe. And this program is based on inquiry-based stress reduction, which is a technique that is included in a 10-day or 16-day workshop series training that is ongoing with a lot of resources and with an online program that is going on and a community of practice gathering that happens every month. So this IBSR, it targets the young people living with HIV aged between 18 to 24. And we also have marginalized young people here, more into self-stigma. And then we have also other interventions that we are doing globally. Right now, we have started also sharing the Wakakosha program with other countries like Rwanda. We have also Zambia. Right now, we are actually having a workshop where we have South Africa and Zambian young people coming in to learn about the Wakakosha. So this is what we have in the Wakakosha program. We have a module that we have created, that we have also co-created with the young people. The young people, they talk about their body and their sex. We have my body and my HIV. And we have shame and guilt, we have forgiveness. So we also have a lot of creativity in our Wakakosha program. So this is what we are actually doing with the young people. The module is co-created for them so that it becomes enjoyable, and then they can also learn and then fight their self-stigma. So in the research, we have done a lot of research, and then we have seen that after the Wakakosha program, so many young people, they come with a lot of transformation. That itself, they realize that they have a sense of purpose. Like me, when I started, I didn't want to do anything. But when I ended, the course, when I ended the Wakakosha program, I said, okay, I think I can also share with other young people like me, and also go into the world and also tell them what I've discovered on myself. And then I started learning and I started improving myself. I also improved my relationships, even with my family, because I did not even forgive the person who gave me HIV. And then after this, I also found self-agency. I also had a positive mind. It also boosted my confidence. Now I can also come here on the OI webinar and talk about it. I didn't even have the courage or the confidence to come and talk. So these are some of the research that we have found. In the Wakakosha program, we have a lot of creativity because this is for young people. We don't want them to be depressed because it's a tense program. So after that, we also have music. We'll share also some of the music if Anna allows us to do so. We can share our song. We've co-created a song with the young people, which is called the Wakakosha song. And so these are the resources on internal stigma that you can also find, that we are also going to share with you afterwards. Thank you so much.
Thank you so much, Maud, for the beautiful presentation. And I already see there are some comments coming in, and also some heart emojis around the Wakakosha. I think it's a very important and really life-changing intervention when it comes to young people and when it comes to also dealing with internal stigma as people living with HIV, and also and I think like Jason spoke to earlier, sometimes as a person who is also a leader, who's also working in the space where you need to support other people living with HIV, sometimes you don't realize the toll that the work itself has on you. And then you need to also be in a space where you can be able to handle some of the depression or the load, the emotional load that you're taking in every time you're supporting other individuals and other people. I think this is really beautiful that you've also really touched on it around the work that you're doing with young people as well, and also sharing your experience and how much of a positive person in terms of thinking and doing that you've become once you've gone through the process of Wakakosha, and also with the support that you've managed to get through your peers as well as the support system around you. This is very good and interesting, and we really appreciate having you here, Maud. Thank you so much for that. Next up, we're going to move on to Tonderai Mareka, who's from Zimbabwe National Network of People Living with HIV, who are currently also doing a campaign on mental health, but also have done a number of work around the stigma and discrimination, as well as mental health. Tonderai, you are welcome to start presenting. And if you can put your presentation in presenter mode for easier visual.
Thank you very much, Anna and colleagues, for such a wonderful way of commemorating the World Mental Health Day. Quite enlightening and learning quite a lot of things. And so I will just share with you what we are doing as Zimbabwe National Network of People Living with HIV around internalized stigma. I think most colleagues shared a lot of things where we also learn. And ourselves, we have done the stigma index study in Zimbabwe, and we are at a stage where we are turning these findings into solutions for people living with HIV, particularly internalized stigma, which was very high, especially among young people, which was around 48% of young people experiencing stigma and discrimination. And it's something that we need to address. These are the leaders of tomorrow, and we need to engage and see how best that issue of internalized stigma can be addressed. And so going forward, so Zimbabwe National Network of People Living with HIV is a community-based organization in Zimbabwe that advocates for the rights and welfare of people living with HIV. And the organization is mainly an advocacy organization and advocate for the conducive environment in terms of HIV prevention, treatment, and care for people living with HIV. The organization works with community cadres to ensure that we reach certain areas that are not easily reached from normal programming in terms of our work. So in terms of the programs that we do, we are guided by our extended 2021 to 2026 strategic plan, and the organization have got a national reach in all the 10 provinces of Zimbabwe. And some of the programs some programs supported are specific to certain provinces, while some are cut across all the provinces. And so the vision of the organization is to ensure an environment where people live positively, and the mission being to improve the quality of life for people living with HIV. And the strategic pillars are around advocacy, communication, and social mobilization, community system strengthening, coordination of the people living with HIV sector, particularly conducting the meaningful involvement of people living with HIV meetings at national, provincial, and district levels, and knowledge management, which is where we situate the stigma index study. It's part of our knowledge management and generation program that we implement, of course, with technical guidance from GMP Plus and other partners, Johns Hopkins University and UNAIDS. And so just to look at mental health and stigma and discrimination, so about 50% of the issues that cause or perpetuate non-adherence to medication are directly linked to poor mental health. It was noted that issues such as stigma and discrimination, forced disclosure, disclosure challenges and side effects, low esteem, or tend to directly or indirectly cause depression and anxiety among people living with HIV. More so, those poor mental health challenges lead to non-adherence, which results in dire consequences such as hospitalization or death. We also have some study findings that confirm that the stressors are a cause of poor mental health, which is a key barrier to adherence among young people living with HIV in Zimbabwe. So mental health and HIV, people living with HIV at times during our interaction in our programs, have limited knowledge and understanding around mental health issues, and the lack knowledge. This lack of knowledge hinders them from seeking help because they cannot detect the problem on their own. At times, if they identify the program, they fail to seek help because they have no knowledge. We also had some studies that have shown that there is a greater need to package mental health trainings and education into information that can be understood by local people as well as fit into cultural norms. This reflects that all attempt at improving mental health for people living with HIV should start with education, educating them about the mental health issues. Then they'll be able to seek comprehensive support from the society and from experts. And then in terms of mental health and internal stigma, access to human rights-based, people-centered, holistic, gender-sensitive, and age-specific prevention testing, treatment, and care support services is essential for the physical and mental health of people living with HIV. What we have also noted is that mental health issues are also taking their toll on older people living with HIV because of social isolation and at times decreased social participation and engagement. Then people living with HIV, especially with advanced age, they are also at risk of developing non-communicable diseases, particularly depression and diabetes. This leads to internal stigma where people living with HIV start to have negative feelings towards themselves, adopting community views about themselves being HIV positive. So what can be done? The approach that we are trying to put that is on the table for people living with HIV in Zimbabwe as we try to turn some of the research findings into real solutions for people living with HIV. We have explored quite a number of issues, and our colleagues from Ukraine talked about the toll-free line which they used in the context of COVID as well as in the context of the Russian invasion. We also, as an organization, have that toll-free which was developed during the COVID time period, and after the COVID period, the toll-free was then expanded to then have other aspects for virtual health support to people in the comfort of their homes. So we have co-agents and some specialist doctors, and of those doctors, we have a mental health specialist who provide services to people living with HIV. And so as an organization, we also acknowledge that Agenda 2030 and SDG states that there is need to promote mental health and well-being. This offers a good opportunity for us programmers to place mental health from the margins, because it was never something that was being talked about to the center of our programming, particularly to improve the quality of life of people living with HIV. So good mental health is about having quality relationships. I think Maud also mentioned about quality relationships, which are very important at family, community, even at professional level. And this should be something that should be done in terms of respect, trust, and building resilience. If you have a comfort landing zone in the face of challenges, I think even internal stigma does not really affect you that much. So the platform that we have is called the Gutabila platform. And so we noted that there's need to invest in enabling non-discriminatory and non-violent environments in all settings, that is family, school, workplace, community, healthcare services, and society at large. So we are currently aggressively putting together some IEC materials to popularize this platform so that people living with HIV or anyone who needs services from a mental health specialist, they can access it through the Tabula. It is, people call for free, the bill is charged on the organization. And so people can get the support from the mental health specialists in the comfort of their home. So when callers call, they indicate mental health issues and the call agents would then refer them to the mental health specialists, and it's something that is still developing, is still being expanded, because so far it is limited to only one network in Zimbabwe, and so it is being upgraded so that all networks people can call, because there's some areas where the network that we are using currently does not have connection, and so we are disadvantaging those people. But so far, we are happy to say that the mental health specialists have been supporting people, and most people get very comfortable in interacting with her because there's not that face-to-face interaction, and at times people, they feel more free to open up to the mental health specialist, even if they disclose sensitive issues to that specialist because they need to be assisted. And one thing that we have also noted on this specialist, we also have our team members, colleagues within the workplace, our workmates who also access the service. They call the mental health specialists as and when they face challenges. And it's something that we are seeing as a good model that is assisting people even in the face of challenges. And for our colleagues in the workplace, I think it's also something that resonates with the theme of this year's World Mental Health Day, which focuses on workplace strengthening mental health response in the workplace, because we have a lot of stressors within the workplace and we definitely need to deal with them. But the issue of internal stigma and mental health, we need not to overemphasize that. Is something that is very important and critical, such that we need to address it so that we build a brighter future for our colleagues and young people who are growing. And then this is my last slide. This is the toll-free line, which normally people will call, and we also have medical doctors, mental health specialists, a legal specialist who are ready to assist and guide HIV positive people. And what we have also done is to have some mapping some services across the country, such that any person who calls from anywhere would know the nearest school, health facility, police station, such that if ever they need that referral pathway, they are just supported virtually through this platform. And this leads me to thank JMP Plus for putting together such a wonderful list of panelists for this program. And thank you very much, Chair, and back to you, Anna. Thanks.
Thank you so much, Chandirai. This has been very enlightening, and it's good to know around how also the platform is really helping as well the workers at ZNNP Plus also to access the platform, to be able to access support when it comes to mental health. And I think that's important also how you mentioned the different environments in which stigma and discrimination is happening, like the work setting, the educational setting, as well as in the community, as well as within the health sector as well. So that's important to know. Thank you so much, Tondrai. And at one point, you need to tell us what kutabila means. Huh? But thank you so much for the presentation. Moving forward, and I know we're getting closer to our time, but we are going to give this opportunity to one of our panelists, our key panelists on the panel today, Afsa, who's going to be sharing some interventions and strategies within the International Labour Organization that are being implemented in terms of supporting mental health and also addressing issues to do with stigma and discrimination. Afsa, you have the floor.
Thank you very much, Anna, and congratulations to my previous speakers for very insightful presentations that they made. And, colleagues, this day to commemorate mental health started since 1992, just to bring awareness about the mental health issues and reduce stigma around it. And it comes every year with a theme. And theme for this year, 2024, is mental health at work. So I'm happy to share a few ideas and insights on that to complement to the knowledge and experiences which have already been shared. If you look at people living with HIV and mental health, and my previous speakers have articulated it very well, I would just kind of reinforce the same messages that stigma, which is related to both HIV and mental health, remains a significant barrier to treatment. And people living with HIV are at a significantly higher risk of experiencing mental health disorders, anxiety, depression, post-traumatic stress disorder, etc. Poor poor mental health is associated with worse health outcomes. We see that particularly in relation to adherence to antiretroviral treatment. But we've also seen that integrating mental health services and HIV in HIV care, it can improve overall health outcomes. And therefore, integrated healthcare approach is the need of the hour. But looking at the theme of the day, I would like to also stress that while treatment and care are extremely important, access to work, right to continued employment, despite a health condition such as HIV, despite a mental health condition, is extremely important, because a conducive work environment is also key to improved health outcomes. Now, in 2022, ILO, along with WHO, developed a policy brief on mental health at work. And this talks about 3 key pillars: prevention, promoting, protecting mental health and well-being at workplaces, and also support, how to support people who have mental health conditions so that they can participate effectively in the workplace and progress in their careers. From the ILO's perspective, there are a number of ILO standards which actually can relate to this. The most important thing is Occupational Safety and Health Convention 1981, which is number 155. The way it defines healthcare, it includes mental health in the definition of health. I have given the link of this policy brief, and you can always take a look at it more. Now, the issue here is, how can we prevent stigma and discrimination related to mental health? First is engage and educate. Lots of education is still required, and we have learned from HIV how and the extent to which education can help in reducing stigma and discrimination. So engaging with people and educating everyone in the workplace is important. Addressing unconscious bias would be extremely important, because mental health is something that comes with lots of biases, and we need to reflect inside, explore our own attitudes. Therefore, all trainings and prevention programs that should be done at the workplaces should try to do exercises and examples where people could reflect on their own biases and change that. And then identify and address causes which fuel mental health conditions. And HIV is certainly one of them, as we have seen. Any kind of deprivation, any kind of exclusion, any kind of violation of rights, and any kind of discrimination adds to mental health challenges. Therefore, we need to take a very holistic look at this whole issue. And finally, raising our own voice would be important to make sure that this issue is not kept hidden, but is brought into discussions. Now, building over the ILO's policy brief, which was in 2022, United Nations had adopted this roadmap for an inclusive and sustainable work environment, where the idea is that mental health and well-being should be embedded in organizational culture. And that is the message. You can read this a lot, but most important thing is it cannot be a standalone activity in the workplace. It needs to be embedded in the overall policy framework, programs, education, and training, and the culture of the organization for it to be a sustainable intervention. So now, if we want to reduce mental health related stigma and discrimination, what seems to be working, and what are the chances of, which are the good things coming up? First thing is, we need to gather data and use that data for advocacy and planning. You heard about stigma index, which is used a lot to do advocacy for reducing stigma around HIV. Same is the case about gathering data, evidence, so that we can do advocacy for reduction of stigma based on the lived experiences of people. I look at the experience which is shared, which coming from the stigma index related to employment status. Of course, one worrying thing is that 32% people are unemployed, 17% have casual or informal workplace. So put together, around 50% people are out of workforce. And they are productive, they're healthy, and they're out of workforce. So therefore, one can imagine what kind of complications it could be making to that. But I also see an interesting finding there, which is about internal stigma, that it decreases with increasing age and when people know their HIV status for a long time. Now, this has lots of insights for tackling mental health in the workplace, where the issues such as support group of employees at the workplace who have mental health conditions. You heard about online support groups which have been created in times of COVID, and those kind of interventions will go a long way, because people who are still shying to talk about it or going for treatment, when they know there is a group that exists, when they talk to somebody who had the similar problem and had overcome that, it would help a lot along. Second thing which would help is prevention through communication and training. Here in the workplace, it's important to talk about mainstreaming mental health in the overall health and wellness initiatives or diversity and inclusion efforts. We can create workplace champions, which has been done in a number of workplaces. Partnerships of workplaces with communities, organizations would be extremely important, because community organizations have lots of experience, as we heard today. And that knowledge can benefit workplaces to come to get the training and right kind of messages for their employees. We have developed a mental health conditions at work online training program. There's a course which can be done by workplaces. The link is embedded into this, just like we did an online course for HIV. So we are going more towards creating tools which could be accessed by anyone and everywhere, from everywhere in different languages, to do these kind of interventions in the workplaces. Now, workplace legal and policy environment is extremely important, because that creates a conducive environment. I talked about Convention 155, because occupational safety and health is a fundamental right now, and everybody should have access to health care services in and through the workplaces. We have Convention 111, and we have other conventions, including a convention on ending violence and harassment, because harassment causes a lot of stress, and that leads to mental health conditions as well. So what we are saying, that we need to identify discrimination and address it on all grounds, because even if it continues to happen because of one ground, we are not going to tackle the issue in its totality. And we should also be cognizant of the fact that there are intersecting dimensions of discrimination. You may be having a person who is coming from the community of identifying as transgenders, but they may also have HIV. They may also have a different gender orientation. So, and a person with a disability may have HIV as well. So we need to really look at all these intersecting dimensions and address that in our programs properly. Now, campaigns to reduce mental health stigma would go a long way, because then you can go in a very targeted way to give messages. We have some examples from HIV. We did a Getting to Zero discrimination campaign when the ILO recommendation was adopted. So those kind of campaigns can be done. And they are done best when you have the engagement of leaders from the workplaces. To give you this example, like we need to engage with leaders like employers and management into this campaign for ending mental health related stigma and discrimination. So when a management, like the management here in case of HIV campaign, said, I have taken the HIV test myself and I encourage my employees to do the same. And those who test positive should not worry, their jobs will be protected and they'll be taken care of. Now, this kind of positive, reassuring messages coming from leaders would go a long way in making a campaign which would encourage people to go out and seek treatment for mental health conditions. Engaging trade unions is also another good idea, and there are lots of trade unions, and I encourage all community organizations to liaise and network with the trade unions in their countries. Here is this trade union from Ukraine, Marine Transport Workers Union. They have HIV policy. They're doing a lot of good work, including the times of COVID. And they intervene at the time when it's most needed, like a seafarer tested positive for HIV, went to a doctor, and doctor kind of was going to inform this to the company, and the person was almost losing the job. So, but then the seafarer approached the union. Union intervened on one hand with the doctor, telling the doctor that we have no right to inform the employer about the status of the person, and telling the management that people can still work with HIV. So keep them engaged, keep them working. As a result of this intervention, the seafarer is back on treatment and is working in the same company. So getting management of the trade unions, leaders, like this person coming from Ukraine says, I've taken the test myself. So take the test today and keep sailing. So those kind of very sector-oriented messages would also help a lot. So these are some of the interventions that briefly I wanted to talk about. And I thought being a discussion on this day would help us maybe capture a few ideas that we could do at the workplace. Thank you very much, and over to you, Anna.
Thank you so much, Afsa, for that amazing presentation. And I really took out how it is important that in as much as we have policy, it's not enough just to know the policy, but it also needs to go beyond and making sure that it's adopted and is part of the organizational culture within any workplace. I think that's very, very important and very crucial to know. Thank you so much for that informative presentation. And to the audience, we will be able to share the links and the links to the resources that were shared by ABSA, and also the presenters that present before that. So as we do come to okay, great. So, and also comms is kindly requesting if all presenters could put their video on so that we can be able to just capture a picture for our documentation. Okay, you'll just give me a sign as and when we're ready, Lesego. But I was saying thank you all so much to the lovely panel of experts that I had today on Mental Health Day and commemorating Mental Health Day with the theme around mental health within the work setting. And I think you all gave valuable insights and valuable information around helping us all understand stigma, discrimination, internalized stigma, and how to go about facing stigma and discrimination within the workplace, and also how to utilize the data that is being collected around the research that is being done with the stigma index, and also from the community experiences and also perspectives that we're learning from. So those were some of the key and very interesting things that I got from today's panel around data for action, which is very important. How do we utilize the data that we have? How do we make sure that the data drives programming, or it also drives action that can change policies and that can also have an impact on people living with HIV. And also what was important was the issue I raised around a policy, being able to make sure that that policy is part of the organizational culture, is part of our programming culture, it's part of the work that we're doing as well. And then also it is important to be aware of also the language that we use in terms of the work that we engage in as we are engaging with communities, to make sure that we're putting the human first and we're using human first language. I think those are some of the interesting things that came out today. And then also, I think most importantly, we need to be kind to ourselves. I think it's important when we're dealing with issues to do with internalized stigma, issues to do with mental health. It's important to always be kind to ourselves, be also more self-aware, and also be selfish with our emotions and also with our space, such that we are also taking care of ourselves so that we can also pour from a very full cup as well. So I think that those are some of the interesting insights that I got today. Thank you so much for everyone that was contributing through the chat. This has been very, very interactive. We're happy to receive any follow-ups through our social media pages, and I'm sure the presenters have also shared some of the information and contact details where we can reach them for any further discussions or any further comments and questions.